Okay, so this presentation aims to clarify the success rates of outside donation IVF cycles in women with endometriosis. But I will also show you that recently the analysis of complex and big data have allowed to obtain very important findings in the field of endometriosis, both from a basic science and clinical point of view. So these are my disclosure. So everybody knows that in women with endometriosis, the success rates of autologous IVF cycles have been reported to be lower compared to women with other causes of infertility. And as a matter of fact, a higher risk of unexpected poor response to ovarian stimulation and a reduced number of site retrieve have been associated with the disease. So women with endometriosis face a higher risk to be directed toward outside donation IVF cycles. And our group has recently tried to clarify the issue, which is the success rates of IVF donation cycles in women with endometriosis, trying to use the most adequate approach according to the available data. So we have used two different research strategies. We did a meta-analysis of observational available study, and we did a retrospective analysis of the IVF registry, in particular the US SART registry and the UK HFE8 registry, of which we will talk later. The meta-analysis of available observational study allow us to include 1,000 recipients with endometriosis and about 7,000 controls. Only 4 studies could be included in the meta-analysis, which is quite surprising considering the great number of centers worldwide that are doing outside donation IVF cycles. 3 of the studies are quite old, 2 of the studies were prospective, 2 were retrospective. The study by Kamat et al. Was based on the database of the UK HFEA registry. Endometriosis was laparoscopically proven in 3 of the studies. In the study by Kamat et al., no information about the diagnosis of method to diagnose endometriosis was reported. In support of the idea that the studies are quite old, in 3 of the studies, the embryos were transferred at the cleavage stage, while only the study by Kamat et al., the embryo were transferred in both at cleavage and blastocyst stage. 2 of the studies tried to correct for some confounders, and 2 of the studies did not. And this is the results. So the meta-analysis of available observational studies showed no significant reduction in live per embryo transfer in women with endometriosis in the unadjusted model that you can see in the upper panel, but even after incorporated into the analysis the adjusted data, the difference between the group was not significant. However, the quality evidence was classified as low because there was a high risk of imprecision bias, and the sample size was considered a critical point. So, as I told you, we have decided to include also data from registry. In particular, we use the US SART registry database consulted from 2014 and 2020. It allowed us to include 1,600 recipients with endometriosis and 180,000 controls. And this database collects all the characteristics of IVF treatment per individual year, including all the outcomes, all the characteristics of the cycles, but many of the data are aggregated, so we could not adjust it for some confounders. Much more interesting is the HFEA database from UK. We have consulted it from 2010 to 2018. It allowed us to include 900 recipients with endometriosis and 24,000 controls. This database collects characteristics of the IVF treatment for each of the cycles, with all the characteristics of the cycles, including, of course, the outcome, implantation, live birth rate. And so for this database, we did a binomial logistic regression analysis adjusted for patient age, egg donor age, and double donation that were found to be significantly different between cases and control. And data from the two registries were also pooled. There are some advantages and some disadvantages in using the data from registry. Of course, the great advantage is that it's a real-world representation. There is no artificial population. Is what is the normal clinical practice. There are no problems of conflict of interest or different regimens of stimulation. You can collect a larger set of data, you have seen the numbers, and you can do international comparison of data sets, which we have done. It is low cost and easy to set up compared with randomized control trials. The patient population is not homogeneous, so you can extrapolate the data because it is representative of the real life. For sure, it has some disadvantages. You can miss some confounders. It needs for sophisticated statistical analysis to compensate for the impact of non-randomization, which we did. You can have some possible changes in the long term, for instance, the classification of the disease. You can have different local conditions in data collection and submission, and the long-term follow-up remains challenging. Anyway, these are the results, the main results of the paper in relation to the registry for live birth rate. In the upper panel, which corresponded to the unadjusted model, you can see that women with endometriosis are considering only the SART database. Women with endometriosis showed a significant reduction in live birth rate for embryo transfer with an absolute difference of minus 3.4%. A difference in 3% in chance of having a live birth in women with endometriosis compared to recipients without disease. Conversely, considering the HFEA database, the difference between the groups were not significant, both in the unadjusted panel and unadjusted model in the upper panel and also in the adjusted model in the lower panel. But as I mentioned before, we have also pooled the data from the two registries, and actually in the unadjusted model show a significant reduction in live birth rate for embryo transfer in women with endometriosis. And if we included the adjusted data from the HFEA database, the findings remain statistically significant. So, these are also the results in relation to the different procedure that has been done in women with and without endometriosis. And you can appreciate that according to the SAR database, the procedure that was mostly significantly affected by the disease was the frozen embryo transfer, always in the context of the IVF donation program. But you can see that the difference here is again very limited because there is a 51.5% live birth rate in women with endometriosis versus a 55.5% in recipients without the disease. Considering the HFEA database, the procedure that was mostly affected was the use of frozen oocytes. So the message of this paper is, and that you can say this message to your patient, is that in oocyte donation IVF cycles, there is a modest reduction in live birth rate between 2 and 4% among recipients with endometriosis. But you have to remember that the statistical significance for this small reduction were obtained only from the pool analysis of a registry. And for sure, we cannot exclude that this smaller reduction is due to the concomitant presence of adenomyosis in this patient. But this paper provides another important message beyond the success rates of oocyte donation program in IVF patients, which is related to the fact that in women with endometriosis, there is this idea that there is a impaired uterine receptivity in women affected, because actually there is this idea that women with endometriosis has a defective endometrium that can support the endometrial determinist theory, or is secondary to the inflammation related to the disease. But you have to remember that at least in IVF, it is very difficult to assess the uterine receptivity in women with endometriosis because there are a lot of confounding factors that can limit seriously our ability to assess the uterine receptivity, because the ovarian reserve, the low ovarian reserve, which is characteristic of women with endometriosis, reduces the rate of optimal embryo to transfer, so it may be the embryo and not the endometrium. Poor responders, like women with endometriosis, are at higher risk of early progesterone elevation that displays the window of implantation. And finally, endometriosis is associated with conditions that per se can interfere with implantation, including adenomyosis, polyps, and endometritis. So the oocyte donation model eliminated at least the first two of these factors. Is a good model to assess the uterine receptivity of these women. And based on what I've said so far, there is only a 2-3% reduction in live birth rate in oocyte donation IVF cycle in women with endometriosis. One may think actually that the utopic endometriosis of these women is not so particular dysfunction, at least for the fertility issue. And the fertility issue of this patient is probably not related to the impaired uterine receptivity. And there are a lot of clinical experts that support this view, mostly of them in the IVF field. But if you talk with basic scientists, they completely disagree with this vision, because basic science, who has evaluated at a molecular level the endometrium of women with endometriosis, they found so many molecular alterations that they suggest dramatic effect on decidualization, embryo implantation, embryo migration. These are only some of the molecules that have been found to be dysregulated in the utopic endometrium of patients with endometriosis. Some of these molecules, some of them are upregulated and some are downregulated. And these molecules are not only important for proliferation, but they are mostly important for decidualization, embryo implantation, angiogenesis, and so on. So how can we match the results of the uterine receptivity from basic science, so many molecular alterations detected, with those from donor IVF clinical study? Frankly, I don't know. Someone may suggest that there may be a role for ovarian suppression, because when you do an oocyte donation IVF cycle, you usually do an ovarian suppression, but for sure when basic scientists do not have an ovarian suppression during their experiment. But what I would like to underline today is very directed to the basic scientists, because now we know very clear that the molecular profile of the endometrium depends on several variables. And some of these graphs represent only some of them. For instance, age has been recently demonstrated to be have an impact on the transcriptomic profile of the endometrium, but for sure the most important variable is the phase of the menstrual cycle. And I want to conclude with this fantastic paper that's been recently published in Nature Communication some months ago, published by the group of Graham Montgomery and Peter Rogers, in which the authors address some methodological challenges in the endometrial research, and in particular the large variation in menstrual cycle length and the huge variability in gene expression across the cycle. At some point of the paper, the author declared that the changing in gene expression in menstrual cycles with different cycle length make the accurate comparison among samples difficult at best, if not completely impossible. So on this basis, they try to develop and validate a new method to accurately determine menstrual cycle stage based on changing endometrial gene expression. And what they found is that there are about 3,000 genes that change expression significantly within a 3.4% period of the endometrial cycles, which approximately corresponds to a 24 hours period in a 20-day cycles. Of these, about 3,000 were during the secretory phase. And I show you one of the example. This is phospholipase 2, in which you can see actually that in which you can see that the expression is stable during the proliferative phase, but then at the beginning of the secretory phase, there is a very rapid peak in the expression, but then the expression goes down and remains quite stable, but goes down during all the secretory phase. And this means that when you apply an omics procedure to your endometrium, the classical definition among proliferative and secretory phase is no longer sufficient to demonstrate that you are collecting a comparable group of samples. So in conclusion, data from the meta-analysis of observational studies show no reduction in live birth rate in outside donation IVF cycles in recipients with endometriosis, but data from IVF registry show a modest reduction in live birth rate of 2-4% in outside donation IVF cycles among recipients with endometriosis, but we cannot exclude a role of concomitant adenomyosis. The significant findings could be obtained only thanks to the larger sample size from registry data. For basic scientists, it is time to reinterpret the basic science experiments on the endometrial molecular profile with a very particular focus on the phase of the menstrual cycle, because as suggested by all the speakers in this Congress, we need to model the complexity and not to try to avoid it. Thank you for your attention.
Let me ask all the speakers to come